Pharmacy Foundation School at NHS England in the Northwest. So we've got a few slides here, and what we thought we'd do is just provide a little bit of context for those of you who are less familiar with some of the changes in pharmacy, and then just dive into the details of the So I think everybody here has filled in an expression of interest for finding out a little bit more information about potentially supporting with some prescribing rotations for our foundation trainee pharmacists. So we'll provide a little bit more information about that, dive into some of that detail, and then there'll be an opportunity for you to ask any questions you like towards the end as well. But like I said, Pharmacy Foundation School at NHS England, and in essence, our team is responsible for supporting the initial education and training of pharmacists. So how we get pharmacists from undergraduate education onto the register. So, like I said, just a little bit of background. Some of you may well be familiar with this, others may not, but in 2021, the GPHC, so the pharmacy regulator, issued new standards for the initial education and training of pharmacists. And this, I think, represented a complete overhaul of the way in which pharmacists are actually trained. So for anyone who doesn't know, pharmacists do an undergraduate 4-year master's level degree, followed by a 1-year postgraduate sort of foundation training year. And that element of the training is staying the same, but there is a complete change to what is expected to be delivered within those training years, particularly around promoting enhanced clinical capabilities and providing sort of a clear continuum from that undergraduate program into the foundation training year. So we now have a single set of, I think it's 55 learning outcomes that cover all 5 years of practice, with a level of achievement expected by the end of year 4, and then an additional level of achievement expected against those same learning outcomes by the end of their foundation training year. And what's really significant in amongst all of this is that it includes the capability to be an independent prescriber. So from 25-26, at the end of that foundation training year, pharmacists who join the register, having been taught against those new standards, which will be probably the vast majority of pharmacists registering that year, will be joining the register with an independent prescribing annotation. And that I guess is a complete culture shift, and also creates quite a significant training requirement. So this is probably a really different model to what we've been used to in the past for non-medical prescribers, where healthcare professionals will have done their initial education and training. They will have then had some time in practice, and then at some point beyond that, whether it's a couple of years or 10, 15, 20 years down the line, they will have done a postgraduate module that included both the teaching elements and the practical training in practice to become an IP. So for our newly qualified pharmacist prescribers, that's going to look slightly different. Their education and training is obviously going to be fully integrated into their degree, and then their time in practice integrated into their foundation training year. And that is, as I said, a significant change for the profession. And why is that important? I guess the drivers to that change, like the drivers across all professions, are linked to improving patient care. So all of these changes are key to addressing things like the NHS long-term workforce plan, in terms of creating a workforce that's able to meet the needs of things like an aging population with multiple morbidities, to manage the complexities of things like polypharmacy and deprescribing, by essentially, I guess, creating pharmacists who are able to deliver high quality care whilst recognizing and I guess leveraging their USP within the multi-professional workforce. So I think some of this is about legitimizing activities that pharmacists have always done in terms of making changes or amendments to prescriptions, but giving them the autonomy to do that in a safe way that allows them to take responsibility and I guess move beyond just making recommendations to other clinicians to actually taking responsibility for medicines themselves, where of course it's appropriate and safe for them to do so. And as part of the long-term workforce plan, it's really important to make sure that we do have enough of these types of clinicians so that they're available in the areas that they needed to deliver care, so that they're capable of cross-system working as our healthcare systems become more integrated, and so that our entire healthcare workforce is set up to meet the needs for future service provision. So what does all of this have to do with you? Hopefully you will have all seen the communications which were attached to this webinar invite. These were created jointly by NHS GM, by the GM Training Hub, by Community Pharmacy GM and us over at NHS England Northwest, which will also have provided some of this context. But I guess as we move into that 25-26 training year, so that's trainee pharmacists that will be starting next summer, these trainees will all need access to some time in a prescribing learning environment and access to a prescribing supervisor, so a designated prescribing practitioner or a DPP. And that is going to be a key element of their foundation training year. They'll have to meet that requirement in order to be able to register as a pharmacist. Now, this requirement may be particularly challenging for community pharmacy. So you may or may not be aware, currently there are probably very few examples of commissioned prescribing services in community pharmacy. There are some where they have IPs delivering, I guess, small amounts of private services, and there might be some places where that's a little bit more extensive. And there are a few things which are laying the roadmap for potentially how this will become more normal in the future, including things like the Pharmacy First scheme, which is using PGDs at the minute, but has the potential to evolve into a prescribing activity. And then there's also things like Pathfinder sites. So some nationally commissioned prescribing services in a small number of community pharmacies with the ambition of rolling that out more widely. But at the minute, for our trainees who start in the 2025-26 training year, the majority of whom are training in community pharmacy, we need to support them and their employers with finding a DPP and a training environment which incorporates that prescribing learning setting. So the ask is that some of you on this call may be well placed to help facilitate this process by enabling your organizations to work in partnership with our community pharmacies to deliver this access to a DPP and prescribing learning setting through the provision of prescribing rotations. And by virtue of the fact that you've all likely submitted an expression of interest, which has led to you joining this webinar, you are at least intrigued enough to want some more information, which is, I think, a great start. Now, I know everyone wants to contribute to workforce development, but also are completely aware that everyone is really stretched at the minute. So just a few bits and pieces on the slide there in front of you. There is a potential for a sort of rotation fee between you and your community pharmacy partner. So that is something that will likely be commonplace and will be a payment to the organization to support with some of the time and resource to undertake this activity. I know we've got a lot of people from general practice on the call. So for people from PCNs, there is also an opportunity to use the direct patient contact funding option within the R's allocation to support an increase in the sessional employment of R's clinical pharmacists to help build some of that supervisory capacity and that multi-professional DPP capacity. Now, appreciate that this maybe won't be a route that's open to everyone, as it is dependent on the PCN's existing utilization of the funding. However, where possible, the scheme could be used to support training and retention, particularly where the PCNs are in a position to do so. Now, obviously, trainee pharmacists can support with workload. We've got examples of trainee pharmacists working in general practice where they've been able to contribute to all sorts and help with workload and capacity. In primary care, they can do some of the QOF work, support with medicines reviews as part of the DES, contribute towards vaccinations and immunizations, and obviously some of that day-to-day workload as well. But I guess at its core, all of this is about maintaining and delivering that pharmacy workforce that's capable of working across the system. So having that input at an early stage and building relationships across the system is really, really important. And it should hopefully help in creating a sustainable pipeline of pharmacists into your organization from a recruitment and retention standpoint. Now, we've seen, I think, the really positive impact of R's funding in the creation of new roles in general practice, but thinking about how we contribute towards the future workforce for this will also be key to its success. I guess it's also an opportunity around developing and improving either your own supervisory skills as a DPP as you progress towards or even beyond advanced practice, and also the overall supervisory skills and capacity within your teams. We've done quite a bit of survey work throughout the Northwest in the past, and many people have found the role of being a DPP really quite fulfilling. It also helps keeps their knowledge and skills sharp and provides, I guess, a positive experience for them as well as their trainees. And on an organizational level, I think it also helps to build those relationships across your local network, showcases your organization and sector's place in healthcare, and helps to show that to a wider array of people. Final thing on that, and probably the other thing to think about, is that Depending on estate capacity and supervision capacity, you don't just have to take one trainee at a time. And there is potentially an economy of scale in thinking about taking trainees in pairs, and we'll come on to that a little bit later as well. Some of the more practical stuff then. So we've got a few slides around sort of who can be a DPP and what's expected of a DPP. I guess some of you on the call may well have experience of being supervised by a DPP or being one yourselves, and that may well depend on when you qualified. So it could potentially have been a DMP, so a medical practitioner. Don't know whether we have any nurses on the call, but it might, if we do, you might have experience of, I think it's having a prescribing supervisor and a separate prescribing assessor. In the context of our trainee pharmacists, there is a set of criteria for who can undertake that DPP role. They need to be a prescriber themselves and working in a role where they're using that prescribing, but that doesn't necessarily mean that they need to be generating prescriptions each and every day. Making prescribing decisions based on assessment can take many forms, and we'll touch on this again a little bit later. They need to be in good standing with their professional regulator and then actively prescribing with the, I guess, knowledge and skills to enable them to provide supervision for a trainee pharmacist effectively. And that concept of trainee pharmacist, I think, is really, really important. We're talking about a really different role here compared to supervising a registered postgraduate professional during their independent prescribing. We're talking much more about supporting and creating novice prescribers that are likely going to need supervision and support beyond registration. So I guess it's potentially a less daunting task than doing that for a qualified professional who might be working already at a more advanced level. And for this, among other reasons, that 3 years experience as a prescriber that a lot of you might be used to doesn't actually apply for people looking to become DPPs for trainee pharmacists in 25-26. In essence, anyone who meets the person specification, which is laid out in the sort of image of the document you can see on the right there, the prescribing supervision and assessment guide, can undertake that role, and we'll share a link to that a little bit later on. There is a range of NHS England support available in terms of describing the assessment activities that the trainee pharmacist needs to do in order to demonstrate their capability. And that final point there, really probably important to note, that DPP doesn't need to be a pharmacist. So it can be any suitably registered prescriber, but it's probably a good idea if you are taking this on to hopefully have some pharmacist input in your team or your wider team, or maybe have a DPP who has some experience of working with pharmacists, just so they can understand the role. And that's going to help provide a little bit of context to the training and the assessments. Now, in terms of what's expected of the DPPs during these prescribing rotations, I mentioned this before, but can't emphasize it enough. It's a very different ask. It's a very different ask to supervising postgraduate healthcare professionals completing a prescribing qualification. We're talking about taking these trainee pharmacists to a very different endpoint, an endpoint where an element of supervision and support will likely need to be present upon their registration in order for them to work within their scope of practice safely and effectively, and then expand that scope safely and effectively as well. So from a practical standpoint, the DPP will be responsible for facilitating the completion of these prescribing assessment activities, whilst ensuring that appropriate supervision is in place for the trainee throughout the duration of their rotation. Now, we're going to expand slightly on what we mean by appropriate supervision in a second, but in the context of the role of the DPP, they're not required to directly supervise the trainee for the entire prescribing rotation. So that basically means you don't have to spend all of your time with the trainee pharmacist during the rotation. Delegating some of this to appropriate members of the team is a perfectly acceptable way to manage the rotation. And I think it can have some benefits for both the trainee and the organization with regards to things like workload, capacity, or even exposure to MDT working. I think the key to all of this is, I guess, finding the right balance so that the DPP can carry out enough direct supervision and assessment alongside collecting feedback from other supervisors who've been involved in the process, or reviewing evidence from other supervisors, so that ultimately they're able to make an informed decision relating to the trainee's prescribing capability. So in essence, they need to spend enough time with the trainee for them to be able to make that overall decision about their capability, just to make sure that they're comfortable that they've learned and developed the skills that they need. And at the end of the rotations, the trainee basically will have had to completed all of the prescribing assessment activities and therefore have a decision from the DPP that they're suitable for registration as a prescriber. But really important to note, that won't be a standalone decision. So you're not going to be out on an island with this. It'll be done in line with and in consultation with the trainee's designated supervisor. So that's their other supervisor who oversees them for their entire training year, and that'll be from the employing organization. So much of this will be in direct relation to the completion of these prescribing assessment activities, which I've mentioned quite a bit. There's going to be an updated assessment strategy designed and released for the 25-26 training year, which will help provide even more information and context for exactly how this is implemented. But for now, over the next few slides, we'll just touch on what these prescribing assessment activities are, just to try and provide a little bit more context. So, in essence, there's 5 prescribing assessment activities in total, and it's really important to note that these may well map across to other activities that the trainee completes as part of their entire training year. And that's why that collaborative approach between the designated supervisor and the DPP is so important. The trainee may well complete elements of these in their community pharmacy or otherwise outside of that prescribing environment. So, for example, first 2 activities here refer to history taking, so documenting and taking an appropriate history, including things like allergies and intolerances, and then physical and clinical examination, which relates to performing and documenting appropriate examinations to decide the most appropriate course of action while you're following those local policies and procedures. Now, each of these activities in isolation don't necessarily have to progress to decision making and prescribing. And there's a host of different examples and environments where trainees could maybe undertake these activities. So some of this stuff could be demonstrated by treating or consulting with patients presenting in community pharmacy, contributing towards pharmacy first consultations, potentially working in outpatient clinics, or supporting chronic condition reviews or chronic condition management. So there's a lot of scope for how this could potentially be completed. Next activity refers to undertaking an actual prescribing consultation. So this doesn't necessarily always have to result in the creation of a prescription, because those prescribing decisions, as you can see on the slide, can obviously include things like modification and deprescribing as well. So what this activity looks to assess through some form of supervised learning events or workplace-based learning is the trainee's ability to assess the patient. So maybe incorporating things from the history taking and examination skills from the previous slide, identifying those treatment options available for clinical decision making, and then presenting those options and reaching a shared decision with the patient. So benefits versus risk, involving the patient in that decision making process, that sort of thing. Enacting a prescribing decision, which, like I said, could include modification or deprescribing, doesn't have to be diagnosis and implementing a new medication. And then providing information and safety netting before actually recording, monitoring, and reviewing. So elements of these will form the foundation of a lot of trainee pharmacist consultations, but this activity tries to assess that in the context of prescribing. And this relates to, I guess, a specific prescribing area identified and agreed between the DPP and the DS. So this is likely going to be the prescribing area within which the DPP operates. So that supervision and assessment guide, which I mentioned previously, describes what this should look like in a little bit more detail. But in essence, we're just looking for an appropriate clinical area associated with the provision of healthcare. Final 2 activities refer to prescription writing and a log of learning hours directly related to developing as a prescriber. So as you can see on the slide there, prescription writing is used as a term to cover a broader concept than just literally writing a prescription. Refers to, I guess, prescribing or deprescribing of medicines whilst considering application of things like legislation, ethical decision making, use of systems and frameworks. So whether that's actual frameworks to help with decision making, so stop-start, electronic prescription services, local formularies, policies, procedures, that sort of thing, clinical governance, and then tools and techniques to actually avoid errors. Now, all that being said, it's probably worth noting trainees obviously aren't actually permitted to sign a prescription or a patient-specific direction, or even authorized by electronic services or anything like that. As you'd probably expect, any final signature and authorization needs to come from an actual registered prescriber. So for something like this, there's a variety of ways that it could be recorded, potentially a log of prescriptions in practice, which were authorized or countersigned by an appropriate prescriber, or potentially another way which helps them to demonstrate the different steps you can see on the slide there. Final point, log of hours, in essence, should include all of the hours spent on completing the other prescribing assessment activities we've just discussed, and potentially any other learning activities that are planned or agreed between yourselves or the DPP and the trainee. Now you can see this refers to 90 hours, and this is what the pharmacy regulator, the GPHC, sets as a minimum amount of dedicated learning, which is focused on developing those prescribing skills for our newly qualified trainee, as newly qualified pharmacists. But I think in the context of these prescribing rotations, where we're talking about a trainee pharmacist, we're likely talking about something between a 4 to 8 week rotation in order to give them the opportunity to embed in a new sector. So it's the minimum of the 90 hours that gets logged, but these 4 to 8 rotations will hopefully provide enough time for trainee pharmacists to understand the systems and processes and then develop and demonstrate the required capabilities. And we'll come on to what actual rotations could look like in a second in terms of training plans and structures and that sort of thing. But before we do, for the potential DPPs on the call, we've covered a lot in terms of your roles and responsibilities. And we fully appreciate that some of you may be more experienced than others, both as a prescriber and potentially as a supervisor. So this slide just provides a little bit more information about some of the nationally and regionally available training resources to help you build the skills and I guess the confidence you'd need to undertake the role. So there's a DPP preparation e-learning resource from the Health and Care Cooperative. There's a DPP training program delivered for those supporting pharmacy professionals from Pharmacists, and there's also a wealth of educator training resources on e-learning for healthcare. Now, this list is by no means exhaustive, and we encourage you to get in touch with us in the Northwest if you want or need some more information about specific support or development. But like I mentioned before, it's probably important to flag none of the training you see on the slide there is necessarily mandatory to become a DPP for trainee pharmacists in 25-26. Like I said before, as long as you feel as though you meet the role specification laid out in that supervision and assessment guide, you can undertake the role. And some of this relates to training and supervision. So things like being able to provide effective feedback and that sort of thing. I guess final point for me before I pass over to Stephen, I think it's just really important to remember, even if you feel as though you're not quite confident enough yet, there is still plenty of time to upskill in any area you feel as though you need to develop in. These rotations won't commence for well over a year. And so there is plenty of time for us to work together to help you get to a point where you can confidently take on the task. And a big part of our role, I think, is to help facilitate that process for you. So you are definitely not alone. So next few slides, I'm just going to dive into a few other bits and pieces I've mentioned in a little bit more detail. So I think I am passing over to Stephen now to cover a few bits and pieces.
Thanks, Pritesh. Yeah, so I'll talk a little bit about the prescribing learning setting and then talk about kind of what rotations could look like and some of the logistics around this. So prescribing learning setting is really saying that the trainee get access to an environment where prescribing happens. And this kind of picks up on what Pritesh talked about in terms of community pharmacy not currently having a broad rollout of prescribing services. The prescribing learning setting is where it's planned for the trainee to undertake those prescribing assessment activities. As Pritesh said, doesn't have to happen exclusively there. So some of that can happen in their base organization as well, but giving them that opportunities to embed in that environment where there is prescribing activity happening. There's a bit of duplication. There needs to be 90 hours of learning focused on prescribing capabilities. And this is around the prescribing activities and other things that help to build that capability. But as Pritesh said, that's embedded within the wider program, both of the prescribing rotation and across their full training year. So really, this is about making sure they have some opportunity in that environment to see those to be integrated within prescribing activities. So thinking about supervision, and I think this is something that lots of you will have experience of in terms of supervising either trainee pharmacists or other types of learners, and that'll hopefully you'll have experience of both registered professionals and those people who are in training and before they registered. The important thing about supervision is that it needs to be specific to the task and kind of agreed with the learner so that you're both confident about their ability to take actions and where there are boundaries around that. So it's not always going to be direct supervision. Where a trainee is involved in professional activities or doing something that would be expected to be done by a professional, they obviously need to have appropriate supervision, but that doesn't have to be you standing over them and watching them as they do it. It might be that they do a set of activities and then have you review them afterwards. For activities that you would get other unregistered professionals to do, once they've been through the appropriate training, they can continue to do that with the same level of supervision you would provide to other unregistered professionals. So thinking about things like that you might get prescription clerks to do, there's no reason why a trainee pharmacist couldn't be involved in doing those with the same level of supervision. Well, in terms of consultations, there's a whole range of consultations that your trainees can and should be involved in. We obviously want our trainees to have some experience of face-to-face consultations, particularly around some of the clinical assessment skills, but bearing in mind, again, some of this will happen in community pharmacy as well. But there are also lots of opportunities for them to undertake telephone and video consultations. And again, there are different ways that can be supervised depending on the content of what that consultation is about. You may want to be on the phone alongside them, particularly early on in their rotation, so that you can intervene. Or for less complex matters, you might be happy for the trainees to make phone calls to patients, to have conversations with them, and then report back to you and have that opportunity to come back to you if there are any questions, because there's always opportunities to phone the person back with an answer. So as long as the trainees understand the boundaries of the conversation and what is in scope for them to talk about, and how to access support, they don't need that direct supervision. There is the potential for remote supervision. I think we have to be really careful about how that's used. So it might be that the trainee and the person who's supervising them are not in the same location. That's very activity dependent, and also making sure that they do have somebody in that environment who they can go and ask immediate questions of if that's necessary. But obviously you might have the trainee there and you might be popping out for a while, or you might not be there all day. But as long as that trainee knows where they can access you if they need you, but also access support from in the immediate environment, that can be used as a way of managing estate's capacity and also managing supervision capacity. And as I said, I think it is really important that we include that patient-facing element to make sure that our trainees are getting experience of interacting with patients, and also the different communication styles and what you can pick up on, what's different in a face-to-face consultation versus a video consultation versus a telephone conversation, and how, as a prescriber, they'll have to manage that. There is a lot of freedom in terms of how you structure a prescribing rotation. We've talked a lot this morning about these rotations being 4 to 8 weeks. You'll see that the minimum requirement is at 90 hours, which is 12 days. But having talked to lots of people as we're trying to plan this, and people who've been a DPP before, people who've been a DS before, people who've worked in different sectors, it feels like we would be setting everyone up to fail if we said they can come in, a trainee pharmacist can come to general practice for 12 days, and at the end of that, you'll feel comfortable that they've achieved all the prescribing activities. So even though they might only spend those 90 hours on the very specific activities, this is more about having the supporting time for them to embed in the environment, for them to understand how the environment works, and also for them to be able to contribute to service, so there's something that you're getting back from it. It can work in any way. We can have single blocks. You could have it as a day or 2 days a week. You can have a combination of the two. In terms of our experience of managing and supporting rotations into general practice under the current standards, we have seen all of these in use. And as part of our evaluation, we've demonstrated that actually no one model is better than the other. It all comes back to good supervision, good exposure to activities, and a good relationship between the two different environments and two different supervisors. Some things that are challenging and that have come out as not working very well is splitting the day unless you are co-located. And even with splitting the day, sometimes the context shift can be quite challenging for trainees, so they don't feel like they get going with in the second environment of the day. So I think I would think very carefully about doing half days. But other than that, all the other models that we have seen, and we have seen a broad range of models, have been successful. And thinking about when these happen, they can really happen at any point throughout the year. I think your capacity, workload, and demand is a really big factor in that. But also thinking about the trainees' year and their continuous development, it would probably be sensible not to have their prescribing rotation in the first few months. You'd want them to have established themselves and developed some of the core capabilities around consultations, communication, history taking, all of that stuff before you'd move into a prescribing rotation. So balancing that, but really other than that, it can be any point within the training year. By the end of their prescribing rotation, you want trainees to have completed all of the prescribing assessment activities, and that they have met these to a suitable level, so that they will be suitable for registration as a prescriber at the end of the training year. So it doesn't have to get them fully to the line. If you think there are things that they can still work on in the other environment, they just need a bit more confidence in certain types of consultations or history taking, then it can still be a successful rotation. And really, there's something about what you as a rotation provider feels the amount of time that you would need, and that also depends on your structure. So which is why we haven't come out and said this is the model you should use. There's so many factors around which days the supervisors work, which days different maybe clinics happen, if you have specific long-term condition clinics that you run on certain days, if you have external providers who come in and run clinics, all of those things dictate what your model will look like. Will you move the slides along if you can? Brilliant. So just as an example, I thought we'd maybe just spend a little bit of time talking through what an 8-week block could look like. So if you had a trainee pharmacist who'd been in community pharmacy and they were coming to you for an 8-week block, somewhere in the middle to second half of their training year. Next slide, Pritesh. You'd obviously want them to come in and have a reasonable amount of induction so that they understand who works in the practice, they understand who people are, and they know what they're going to be doing with their time there. You'd, at the start, look at the prescribing activities, look at what they've been doing in the training year. Whoever's acting as their DPP or as a second DS will have access to their e-portfolio, so we'll be able to see the evidence they've already generated and their progress with their learning outcomes. You then want to have a prescribing development plan, which will probably have been relatively well described in your training plan already, but now is a chance to kind of identify where the trainee is doing particularly well and you might want to change things, or if there are any areas for specific development. And then agree when and how the trainee is going to undertake the prescribing assessment activities. Next slide. Then during the rotation, the trainee would have an opportunity to undertake activities with both the DPP and other appropriate members of the team. That may involve some time with non-prescribers as well for some of the activities. There's no reason why they couldn't be in a clinic with a non-prescribing clinician to do some history taking. So there's lots of opportunities to work with appropriate clinicians across that those middle weeks, but also to do other activities as well. So not everything that they do will have to be directly related to prescribing. They may be doing other things for you, like doing well man or well woman clinics, so they get opportunities to take history, or they might be, you could have them involved in potentially vaccinations if it's the right time of the year, working on their communication skills, consenting people, or all of those kinds of things. So there's lots of opportunities for them to be involved in that, and also some less direct patient-facing activities, so doing desk-based medicines reviews, working on their clinical reasoning and identifying medicines optimization opportunities, working on audits or searches, so understanding that kind of prescribing governance and prescribing safety. So lots of opportunities for them to be doing all of those activities across those middle weeks. And then when they get to the end, so the final week, they would have that meeting with the trainee pharmacist and the DPP and their DS and confirm that they've done all of those prescribing activities that were required and that they have done them to a suitable level, considering a new registrant novice prescriber and what you'd expect of them. So that's one model. So that's kind of an 8-week block. And as we said, it might actually, you might feel that you could deliver all of that in 6 weeks. And that's about finding the model that works for you. But there are a range of models. So you could have, as I said, that single big block. You might think, actually, what would be better for us is to have the trainee here a day a week, because there's a specific day where they're DPP, so they're PCN pharmacists maybe in the practice on that day, or there might be a specific clinic that runs on that day of the week, and you think that's the day I think that the trainee will get the most out of this. So actually, we'll bring them in and give them a 1-week induction so that they understand the practice, get to know who people are, and then actually we'll get them to come on a Tuesday for the next 6 to 8 months, depending on what they're going to be doing and what you think is needed for them to achieve the prescribing activities. Perhaps you'll say 2 days a week would work well for 4 to 5 months or a shorter amount of time, but still giving them that equivalent of 6 to 8 weeks of experience. Or maybe 2 blocks. You might bring them in earlier in the year to understand how general practice works and get to grips with it and start off with some of that activities, then return to community pharmacy full time, do some consolidation of that kind of spiral learning, taking what they've learned about consultation skills and history taking and prescribing decision making, develop some further community pharmacy, and then come back for a second block later in the year. So really, these are just 4 examples of the infinite ways in which you could put a training program together that works for you. I think I've got another couple of slides. So the next slide, thinking about where the trainees can both contribute to service but also be developing. So the things that can do around working in clinics, both being there present and having an opportunity to do some of that, but also some of the pre-work. So doing the medicines review before the patient comes in, kind of gathering all the history, doing that stuff, identifying patients who would benefit from certain interventions. They can do all of that in advance to support clinics. They can work with the pharmacy and prescription teams around resolving queries, around requests for medicines and processing those, and also making sure that they are safe and identifying opportunities for optimization, medicines reconciliation of discharge prescriptions, involved in QoF activities around identifying patients and making sure they're recorded, making sure they're in for their monitoring and their reviews and all of that kind of thing. As I said, contribute to medicines reviews, both in terms of the desk-based element, but also the actual in-person reviews with the patients. There might be opportunities for them to contribute to vaccinations. Most students will have had some training on vaccinations as an undergraduate. They may have had training on vaccinations in their community pharmacy, depending on what services they're running and how they're running them. There's maybe less of that going on now, with as most of it will be PGDs, but there is opportunities for that. And you may feel that training them up to deliver vaccinations is a good way of you getting some return on that investment for them and helping to develop them for their future as a pharmacist. As I said, things like well man or well woman checks, so those NHS health checks. And in that supervised delivery of non-complex consultations, these trainees will have had their 4-year undergraduate where they've had some placements. They may well have worked in pharmacies or in that environment, and they will also have done, depending on when they come to you, they may have done 6 to 8 months as a trainee already. And so they may already be able to deliver some non-complex consultations for you with minimal supervision. So some of that will be about assessing your trainee when they arrive. Next slide. So just thinking about taking multiple trainees, there is an economy of scale. If you're doing this work to set up a program, you might be able to do it for more than one trainee. The biggest barrier to that is possibly estate's capacity and having access to IT. But if you have that, then this is definitely something to think about. The structure remains the same or similar. So it might be actually, if you're taking a trainee for 1 day a week, that you could do that with 2 trainees. So you bring them both in for induction at the same time, and then you have one of the trainees on a Tuesday and one on a Thursday. Maybe you swap some part down some part way through the year so that they get experience of what's happening on the other days. But there's that opportunity for you to have an economy of scale and also potentially create a peer network depending on how you do that. That can be staggered as well. You might take trainees back to back, so you might actually have them for a block, but then have another trainee afterwards. As I said, it creates that peer network, but also increases the contribution towards the workload. And there's an opportunity to align the rotations with your organizational need in conjunction with your community pharmacy partner. I think, is it just, yeah, one more slide, which is just about where you can find out more. We will share these slides so that you have access to them, but there's lots and lots of information on the NHS England website, and we're more than happy to come and talk to anyone, kind of have an individual conversation with you if you're trying to build up your training plan. We will later in the year, so bearing in mind that it is a year before these trainees will start, and it will be October, November before we know where trainees have been placed in terms of which employers are with. After that, we're more than happy to work with people on designing your training plan and what that could look like. So we are here to support, as are the ICB team. I know they're happy to support, and Lovejet and the Training Hub team as well. So there's lots of support around you if this is something that you're interested in pursuing. I think that's the final slide. Yes. So happy to take any questions from anyone. I think we did have a few questions in advance that we might have addressed in part with the presentation, but we can answer those as well. Do you want to stop sharing, Pratesh?
Yeah, I'm just doing that now. There we go. So thank you to as you all maybe have a little think. I know some of you submitted some bits and pieces before, and I think we've probably addressed the majority of those through the presentation. I can see Alex has just popped a question in that chat there. Would any changes to indemnity insurance be needed as a supervisor? So Stephen, I'm not sure whether you know the particular...
Yeah, I guess it depends on your current indemnity and what your employer indemnifies you for. So it's definitely worth having a look at that and making sure that within your indemnity insurance, it covers you for being a supervisor. Again, the risks are probably relatively low. I guess there's a consideration around the regulatory element of it and the GPHC or your regulator if you're not a pharmacist. But yeah, I think it's definitely worth checking. I think a lot of from previously looking at this, a lot of insurers include that within their standard protection if you've got indemnity.
Is there anything else from anyone? I know there was a question previously around the fact that Oriel had already closed and whether programs within Oriel should have a DPP in place already. So Oriel, for those of you who don't know, is just the recruiting platform that we use for all trainee pharmacists. So every trainee pharmacist in 25-26 will be going through Oriel. So at the minute, we're at a point where the programs are live, everything's been submitted, and trainees are actually preferencing which programs they would like to be recruited to, and then that'll be based off of their performance and various different metrics to see who gets allocated to what. In terms of some of these programs will have a DPP in place already. There isn't a formal requirement that each and every program right now needs to have had that DPP in place, which is why a lot of this work is going on to try and find that DPP capacity for those particularly community pharmacies who are still searching for who that DPP is going to be. So there isn't a formal cutoff at the minute in terms of by this date everybody needs to have this in place. However, we're working towards timelines of trying to get this done as soon as we can, just to make sure that the programs that trainees get preference to are viable and have that DPP in place, just to make sure that the training and everything can be set up beforehand. I believe there was another question previously regarding whether attending this webinar, after attending this webinar, you could take trainee pharmacists who are doing IP courses at the university and act as a DPP for those tutors. So the DPP requirement for trainee pharmacists in 25-26 is a slightly unique in terms of the requirements for who can be a DPP is literally spelled out by that supervision and assessment guide and the role specification that's within it. So I know I'm going to be sharing those slides afterwards, but I will just pop a link to that in the chat as well, just so you have it. In terms of being a DPP for university programs, that is going to be very much dependent on the university provider. So each university might have slightly different requirements for who can be a DPP for that particular program, whether that's for pharmacists or anything else. So it's probably worth double checking with that university first and foremost to see what those requirements are and whether you would map across to that. But in terms of trainee pharmacists for 25-26, the document I've just posted in the chat there is a role specification. And as long as you feel as though you can meet that role specification, you'll be able to be a DPP. And Stephanie, you got your hand up there.
Thanks, Pritesh. I was just going to add to that with the standalone prescribing qualifications, you usually need 2 to 3 years experience of being a prescriber before you can supervise. So it is different. The requirement is different with this. You don't need to have as much experience. And I think, as Stephen and Pritesh said, that's because the expectation of what these prescribers will be able to do is different. They're still going to be foundation pharmacists. They're still going to need to have some supervision. So I think that's reflected in the DPPs not needing to have as much experience themselves. So I suppose in a way, this is like the first step. So if you're interested in being a DPP, this might be a really good place to start with your trainee pharmacists. And then once you've got one of them and supervise them in their practice placement, it will then give you a really good foundation to go on and supervise students on the standalone courses.
Brilliant. Thanks for that, Steph. I think the remaining questions we received beforehand related to things like skills and what it involves to be a DPP, potential training, and whether you could opt in at certain times. So I think we've touched on that throughout the presentation, but is there anything else from anyone? Please feel free, either just unmute yourselves or pop it in the chat, absolutely fine. On that note, then,
hopefully we've answered all the questions. Yeah.
I was going to say, does that mean that everybody's going to be supporting foundation trainees? I hope so. And I think, I just wanted to say it's a real opportunity now for you to just, because sometimes offline, I've definitely had feedback and concerns. This is a great opportunity for you to flag it, because we're all here. And I think it's fair to say, isn't it, Pritesh and Stephen, that we're all here to support. And, the email address has been provided. So even if you don't want to share it now, do make sure you get in touch and don't, just reach out, because there's a lot of support available to get you to the point where you can do it. And I think the requirements, as Steph very, rightly said, are a lot less than, in other sort of settings. So, and I think it's important to say that this is about developing our workforce pipeline for the future. And so these foundation trainees are also going to form the workforce for community pharmacy and general practice. So I just want to say that it's already very difficult, and we need as many people engaged, and we need as many people as we can, so that we can create our future leaders. So your support and integration and working with us would be so much appreciated. And just to say, there has been a lot of system engagement. We have been out to GP board, primary care board. There's been locality conversations. It's been flagged at some of the ICB forums to make sure that there's wider awareness. But if you can spread the message and the comms amongst your colleagues and teams in your PCNs, that would be so much appreciated as well. Thank you.
Brilliant. So I guess in terms of next steps, we'll be in touch after this webinar to explore those next steps and how you can specifically get involved to form those partnerships with community pharmacies in preparation for next year. And I guess we've said this quite a bit, but as you form those partnerships, we will be around to provide support with describing what those good rotation models look like, recognizing that it won't be the same for every organization and every practice, and that there are a lot of ways of making that work. But we can make that a joint effort to make sure that you've got all the support you need to make that successful for you and your practices. So I guess if there's nothing else from anyone, just a massive thank you all for your time. Really do appreciate it. It is a really exciting time, I think, around the development of pharmacy, and it would be great to get all of you involved. I know everyone's busy and probably maybe a little bit overwhelmed at the minute, but there are, as I think we said, some real benefits to around this, around creating a workforce for the future. And it's not for delivery straight away. So there is plenty of time to get everything in place before that 2025-26 training year. So thank you all very much.
Thank you.
Thanks, everyone. Bye.
Thank you.
Thank you.